What's Up? Doc Mike. Public Health on Call. By Johns Hopkins Bloomberg School of Public Health. Today's topic for December 16, 2020. Why COVID-19 cases in Africa are much lower than expected. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Stephanie Desmond talks to Tolbert Nyanswa, a former Liberian health official and current research associate at Johns Hopkins, about COVID-19 in Africa. They discuss the reasons why the case counts in Africa are dramatically lower than those in the United States. Let's listen.
Tolbert Nyanswa, thanks so much for joining me.
It's a pleasure. Thank you to be with you, Stephanie.
I'd like to talk today about Africa, where the COVID cases are much lower than I think we might have expected. So just to start with a comparison, there are about 2 million cases of COVID in Africa and 50,000 deaths versus 12 million in the United States. And Africa is 4 times the size of the United States. So my first question is, what's going on in Africa with COVID?
I think the alarm bell and alert warning system was put in place in time, certainly because of several factors. Number one is the scare from Ebola. Ebola and other infectious diseases that Africa has been dealing with, measles, polio, Lassa fever. So the alarm bell went on very, very fast, and people got serious about the outbreak of COVID-19 because of the experience with Ebola. Similar thing with East Asian countries with SARS and all of that. So I think that's helped with early preparedness, response, and timely standing up of infrastructure for emergency preparedness and response.
I also understand that the age of Africans is very low, that more than 60% are under the age of 25. Do you think that that's been a factor?
Age is an essential factor for the lowering deaths and cases that we see in Africa. And the reason, Stephanie, is very simple. As you said, the young population that we're looking at with COVID-19, the number one predisposing factor is age, followed by pre-existing conditions like diabetes, heart disease, stroke, cardiovascular disease, and all of that. With the young population in Africa, COVID-19 being a moderate disease, not a severe disease as Ebola, has contributed immensely to the lower cases and mortality.
So I know that the health systems in Africa are not as advanced as the ones in the United States. So one would think that Africa would see higher number of cases and mortality. Are you surprised to see the numbers the way they are?
Not only surprised, but it's astonishing to see the United States with the sophistication, high income country, very high income country, rich country with a robust healthcare system to be struggling with COVID-19 as compared to countries in Africa with all of the challenges in this healthcare system, coupled with infectious disease, HIV and AIDS. And if you talk about human resource for health, there's acute shortage of that. Healthcare systems are weak because of many factors like war and other things that are going on in Africa. So, but the fact is, with my experience dealing with Ebola and Lassa fever and other diseases in Africa, and the polio eradication program, for example, if you took Nigeria had a surveillance system and incident management system that there with Ebola. We have set up the National Public Health Institute in Liberia, the Africa CDC. So if you put all of these together, the US is having response capacity like textbooks.
Yeah. Yeah. It's an interesting question. And I guess the question that comes to mind, I was looking at the numbers, and South Africa has almost half the cases in Africa and, 2 of every 5 deaths in Africa. Is that because they're doing more testing is a question. So I guess one of the questions here is, are the case numbers in Africa perhaps lower than we know because of a lack of testing?
The surrogate of mobility is mortality, meaning if there were cases hiding somewhere, you will see more deaths of the COVID-19. If there were cases hiding somewhere, you will see deaths. So for one to say that because of the numbers is because of lack of testing or reporting, I may agree because of data issue, health management information system and reporting is a challenge, but it's not really that. Some of the factor is, for example, when we saw it about age, it's a contributing factor. Part of that is the response capacity and how Africa was able to move very, very quickly and fast. African government with the WHO Regional Office for Africa, with the Africa Center for Disease Control now established after Ebola, and African countries have stood up the national public health institutes on the continent, like the Nigeria CDC, Liberia National Public Health Institute, and the regional collaborative centers for the African Center of Disease Control. So countries that prepare in global health security, South Korea, country in Southeast Asia, have done tremendously very well with the global health security that CDC, the US government, was putting out there in the developing countries. Those countries that invested in global health security did a very great job than those countries, that the high income countries that have just the theory of epidemiology, disease prevention, incident management system, and did not practice it in terms of dealing with those diseases. That's what I think are contributing factors.
So the U.S. has really helped Africa to do a good job on this.
Oh, of course. The U.S., the global health security agenda that was set up during the Obama administration, that being led by the U.S. CDC in Africa. I was on the field. I saw that right hand in setting up incident management system when we started Ebola, emergency operations centers. African countries now are doing well in their joint external evaluation as a preparedness for reporting for the international health regulation and all of that. So U.S. help countries, and this is why, Stephanie, I'm very much astonished why we're not doing contact tracing well here in the U.S., why the testing is not point-of-care testing that we can do it very quickly, why are we not isolating people very fast, tracing their contacts at least 90 to 95%, and people not doing social distancing. These are the tools that we have in the tools belt right now. The vaccine discussion is good, but before we find vaccines, these are the things we have to do.
Absolutely. I've also imagined that one reason why the spread hasn't been as broad in Africa is because there's not as much travel that takes place. Do you think that could take some of it into account?
Outbreak response, when you have an infectious disease that is spreading fast like COVID-19, you restrict some of the rights. And one of the things that I see here in the US is about people don't telling me what to do. I have my rights. I can do anything I want to do. You can't have the cake and have it at the same time, but you have to have some measures taken, that government cohesive messages and systems that people will follow. When they say, restrict movement, people should listen to that. Just simple rules that can save lives. We save lives first, then we reopen the economy and reopen schools and all of that. But what I see here, we want to do the two things at the same time, which is very difficult.
Are there restrictions in your home country of Liberia?
There were. From the initial state, all of the African countries, they follow one model: close their borders, close down airports. They told people they were locked down, very, very stringent measures of lockdown. Like you saw in China, over a billion population, that was one of millions and millions of people were locked down. And those measures were taken in Africa. That's what I call the alarm bell went on very, very quickly, and people took alert actions, and those government declared state of emergencies and all of that. Those are not traditional public health measures, but they help so that you put in some systems in place. I was not in support of lockdown in Africa. The reason is that people don't have food to eat. The economic situation is bad. Water and sanitation issues are poor. You cannot keep people home and then tell them that you lock down. But you can do the measures that are public health. Trace the contacts, test people, social distance, washing hands, wearing of masks. These things are effective. They do work. One of the things I'm concerned about, maybe you want to bring it up, is the issue of vaccines.
I was just going to ask that question.
Oh, I say, great. Please.
Go ahead.
So one of the things that I see that very much important that we need to look at and critical is how low middle income countries like sub-Saharan African countries, the availability of the vaccines that we're talking about today, the Pfizer vaccine and all of the other candidates that have been approved, the global competition with the vaccines getting out. Now higher income countries with more money need them. The issue of equity, and Africa is fixed with huge supply chain, logistical management issue, coaching of the vaccine. You know, the vaccine have to be stored under freezing temperature and all of that. How do you deal with it? The number of doses, is injectable. It's not like polio vaccines that you have 2 or 3 drops in a month that can be taken very, very easily. Training of vaccinators, and looking at issues like storage and coaching, handling, large-scale communication and outreach, and getting the vaccines to the household level would be the critical challenge that we need to look at and start planning for right now. Because if you deal with COVID in America, deal with it in Europe, and leave out Africa and other developing countries, you're not solving the problem.
Well, Tolbert Ninswa, this was really a great conversation. So thank you so much for sharing your insight.
Thank you, Stephanie. I appreciate it, team. Thanks. You're doing a great job with the podcast and keeping our people aware. Thank you.
Thank you.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.